In today's session, we will hear from both Liz Scudamore, a paediatric stoma care nurse based at Sheffield Children's Hospital, as well as Alison Kennedy, who is a paediatric stoma care nurse from Sydney. Both Alison and Liz have a wealth of experience in caring for babies and children with stomas. In this session, they will share practical aspects of stoma care that adult specialist stoma care nurses may find useful. Alison Kennedy is a stomatherapy nurse who will re-examine some of the paediatric conditions that can lead to stoma formation.
Hello, my name is Alison Kennedy. I'm a paediatric stomaltherapy nurse from Sydney, Australia. The purpose of this presentation is to introduce you to the common indications in infants and children who require fecal stomas created. The medical conditions that children and infants generally require a stomal surgery are listed here. The first 6 generally are in infants, and the remainder are for older children that you will see. For the purpose of this presentation, I'm going to discuss in more details anal rectal malformations and Hirschsprung's disease in infants and why they may require stomal surgery. Due to time constraints, the other conditions will not be discussed. We will look at the most commonly formed stomas in infants and address some of the practical challenges faced when managing paediatric stomas. With anal rectal malformations, they are congenital. They affect 1 in 5,000 babies, but the numbers seem to be increasing, and some institutions are reporting as frequent as 1 in 3,500 births. Typically, the anus is not present, or it can be in the wrong spot, or it looks abnormal. 50% would be an isolated incident. There are various types, and as I mentioned before, they are broken down to where the fistulous opening occurs. So in both male and female babies, we can have an anal rectal malformation without a fistula, and that means that there is no opening in the perineum, and that no anus visible when the baby is born. The rectum actually ends in a blind pouch, so the newborn cannot pass any stool or meconium. There may be a dimple where the anal opening should be, but often there is nothing there. So in the newborn check, it is picked up then. The baby will often develop a distended abdomen with plus or minus vomiting and require a stoma soon after birth to allow for that fecal diversion to occur. In the rectal perineal fistula, or perineal fistula, as it's often referred to, which again can occur in both male and females, the opening is closer to the vagina or the scrotum, more so than normal, and may be partially or completely in front of the anal sphincters. The perianal opening is usually big enough to allow some stool to pass, so they do not develop the emergency symptoms such as the distended abdomen and vomiting that the babies with no fistulas occur. Depending on the size of the fistula, the baby may successfully pass stool without the need for a stoma until the corrective surgery is done. Where it is small and the infant struggles to pass stool or struggles with constipation, stomal surgery then may be necessary. In girls, where the fistula opening is close to the vestibula or the vagina, the same applies. If stool can successfully be passed, then a stoma may not be necessary. Although some surgeons will prefer to have a covering stoma so that when corrective surgery is done, the neo-anus is protected from fecal contamination until healing has occurred and reversal surgery can be done. Cloaca is only occurs in females, and it's a rare condition where the urethra, vagina, and anal canal are merged into one common channel. Stoma surgery is performed soon after birth to protect the urinary system from fecal contamination. In males, the fistula may end anywhere along the urinary tract, including urethra, prostate, and at the bladder neck. This stoma surgery would be performed in these cases to allow protection of the urinary system, and because urine simply couldn't be passed through that down the boy's urinary tract. So this is a picture of a typical looking anorectal malformation without a fistula, so no anal opening, and there would be a blind end to the rectum. So this would require emergency surgery soon after birth. With the rectal perineal fistula, you can see the opening very close to the vagina in this case, quite small, but when the baby is a newborn, meconium could quite successfully be passed through there. But as stooling gets larger and bigger and thicker, then it may be necessary to do the surgery to divert that feces. Obviously, I can't show any pictures of the internal fistulas, but I've described them previously and how they occur. So we're going to move on to the Hirschsprung's disease. This also is a congenital disorder of the colon. Similar rates to the anorectal malformation. The reported incidence is 1 in 5,000 births, but here we have a prevalence in males 4 to 1. Anorectal malformations, it's equal reporting. And this condition involves where the ganglion cells, the nerve cells that create a peristalsis wave along the large intestine, are absent in parts of the large intestine. The length of the bowel that affects does vary. It can be what we term short segment, and that's from the anus backwards, and then it progresses approximately along the length of the colon. That's determined by doing biopsies to see where the ganglion cells restart. With the presentation in infants, it's most commonly diagnosed in the first week of birth. The most common feature or indication would be that the baby does not pass meconium. They develop a distended abdomen, vomiting, non-toleration of their feeds, losing weight. And when their anus is examined, they tend to have a very tight anal sphincter with an empty rectum because the stool has not progressed or the meconium has not progressed down into the colon. A rectal biopsy can be done at the bedside, but that will only allow us to see in the first part of the rectum whether ganglion cells are there or not. When ganglion cells are identified, then the baby is managed just by passing a rectal catheter to allow the stool to come out. But when there is none, a covering stoma is created until it can be determined what length of bowel is affected. They will often present when it's been a fairly late diagnosis, as in after the first couple of weeks of life, with an enterocolitis type illness that they get diarrhea, fever, and they become very unwell. Although they have been passing stool, we can diagnose with rectal biopsies again that they have Hirschsprung's disease. With the Hirschsprung's, not all of them require to have a fecal divergent stoma, but if we cannot determine the length of bowel that's been affected, then a stoma is created until corrective surgery is done. So I'm going to move on now to the actual types of stoma that we see mostly in children, very similar to adults, but I'll just explain the most common one that certainly the paediatric surgeons would use. So obviously depending on the part of the bowel that's exteriorized, it's either going to be an ileostomy or colostomy. The vast majority of paediatric stomas would involve the ileum and an ileostomy. There are the end stomas, which would be quite rare in the paediatric population. A loop stoma, which is relatively common. And the reason for that is that most children, infants and children's stomas, are a temporary thing. And the aim is always to have them closed. And by having a loop stoma or a double barrel stoma with mucus fistula enables the surgeon to do that fairly easily. So this would be an example of an end stoma. It's obviously a colostomy. It's quite large. This isn't long after surgery, but it's situated in the transverse colon, just above the umbilicus, and it's fairly well spouted, and certainly we didn't have any issues with this one. This would be an example of a loop ileostomy. As you can see, both proximal and distal ends of the bowel are exteriorized. They are fairly equal in size, and this means that both parts of the bowel have to be accommodated within the aperture of the stoma bag. This can create some problems, particularly with small neonates, because the bags are designed to be quite small, but the base plate tends to be small, but we have to cut quite a big aperture from that. So having the right size aperture and base plate often means that we have to put a bigger bag on than is necessary for the babies. Again, these are loops, but I was just wanting to show you the different shapes and sizes that we see. In the first one, you can see that the actual mouth of the stoma is located laterally and not on the top of the stoma. So this little one had some skin exploration because of that, with the drainage of the fecal effluent coming directly onto the skin, despite using seals and the appropriate size bag. And then the other one is just showing you that the actual proximal and distal stoma are quite different in size. This would be a divided double barrel stoma with a mucus fistula, and again quite different in shape and size. Sometimes the mucus fistula is quite difficult to see. When it's very small and flush to the skin, it can actually be put under the base plate. It doesn't have to be cut in the opening of the bag, which makes it quite easy to manage these small stomas. But on the second photograph, we have quite a pronounced proximal stoma, but also the distal stoma is quite large and not flush to the skin. So there's a skin barrier, a bridge of skin between. So that was, we needed to be quite inventive with the cut out of the stoma bags for this one. Some of the challenges that we have with the pediatric stomas are highlighted in these pictures, these images that you can see. The baby, unfortunately, had a very regressed proximal stoma, resulting in some very sore and excoriated skin, which made the bag adhesion difficult for us. Luckily, his distal stoma was quite flush to his skin, and we were able to keep that covered by the actual base plate of the bag. So we managed this challenging problem by trying to have his skin in a good, healthy state. We used powder, stoma powder, to increase the adherence of the bag, to dry out the skin surface. He needed a soft convexity, which can be quite challenging in infants, but it seemed to work quite well and managed to direct the fecal flow into the bag. We didn't have to accommodate the distal stoma within that flange. When we look at this image, we can see a large proximal stoma which has come through the laparotomy wound. There is mild dehiscence on the medial side, and we also have a fairly flush distal stoma, but quite some distance away. It did have to be accommodated within the base plate. It couldn't be left exteriorized. So we used a fairly large adult size bag. The laparotomy wound plus the skin between the stoma, the proximal stoma, the large proximal stoma, and the distal mucus fistula was protected by using a seal, which was cut appropriately to cover those areas. And then the bag was cut out, not with two separate opening holes, but one large opening hole because the skin between was protected by the seal. And this was quite successful for this patient, and we managed to get healing of that area. And another issue that we do see with children is retracted stomas. And this was a little one that you can see that we had a few issues with as well. And there is a mucus fistula in there somewhere, but quite hard to find that. Another little retracted stoma, very, very small. That was actually the proximal stoma. The mucus fistula was in there somewhere as well. This baby didn't need emergency surgery, unfortunately, because it became so small. And one of the other challenges, because I did want to show and discuss a little bit about some of the challenges paediatric nurses do face, is that the baby's abdomen is very, very small and we don't have a lot of space. So that's often why the surgeons do have to bring the stoma out through a laparotomy wound, but we also have to consider in the newborns when they have their umbilical stump still attached. So again, this caused a few challenges for us, but we managed to get there. So with the bag going across when you have that stump there. I think that's all the pictures I have to show you today. Thank you.
That is so interesting. Thank you, Alison. Sometimes caring for such tiny stomas can be so challenging. We are so fortunate in Stoma Care that we now have access to so many more innovative products and devices to help us meet the needs of our patients, no matter what size they are. We will now hear from Liz Scudamore, Paediatric Stoma Care Nurse at Sheffield Children's Hospital. Liz qualified over 20 years ago with a degree in paediatric nursing. She worked in Alderhay and Adderbrooks before settling in Sheffield. In Sheffield, Liz developed a keen interest in colorectal surgery and went on to study for a community practitioner degree. In 2014, she was appointed into her current role, which encompasses care of children with stomas and bowel-related continence problems, both in a hospital and community setting. Liz is a keen member of the Paediatric Stoma Care Nurse group and has a particular interest in developing and improving the transition pathway for young adults with stomas and bowel-related continence problems. Today, Liz will be discussing the specific needs that a child living with a stoma may require to enjoy their time at school. The things that perhaps we, as adult stoma care nurses, may need to know if we have a child with a stoma transferred into our care.
So all children and young people with a health need should be able to enjoy the same rights and opportunities as other pupils in school. A stoma should not prevent a child from being healthy or active, and with the right support, they'll be able to reach their full potential. So within this session, I aim to cover what I see my role as a stoma nurse specialist is in helping them achieve this. For a child going back to school with a stoma, it can be an anxious and challenging time. So I'll look at the most common questions a child may have and their parents, and also look at it from a school's perspective. I'll discuss what training I would deliver to schools and how I would deliver that. That will no doubt differ from centre to centre. And also look at topics that arise as part of the school day and discuss care plans and health educational care plans that a child with a health need in an educational setting will need. And also any training documentation that may be used. My main aim is to provide as much support and to the child and family that they need to all feel comfortable and confident that they're going to be supported and well looked after in school. It's really important that the school responds in a positive way when accepting a child with a health need back into school, as a positive experience in school is vital in securing good outcomes for that young person or child. And also to try and ensure that this happens, it's important that the school staff receive the right education, training, ongoing training and support to be able to care for that child competently whilst they're in their care. I'd also help contribute and collate information that will make up the care plan or educational healthcare plan that they have in school. So the prospect of returning to school after having major life-changing surgery can be extremely daunting for a child of any age. Not only are they learning themselves or their parents are learning how to care for their stoma, they're getting to know how the stoma impacts upon their life, having to cope with changes in body image and the psychological impact it will have, but they're also having to return to a school environment that presents a lot of new challenges and questions and worries. All children will have some questions. Some will be more important than others, depending on their age. If these questions can be discussed prior to returning to school and possibly talk through potential situations that will occur and what they would do in that situation, it will hopefully help them or their parents feel more prepared and a little bit more confident about returning to school. These are some of the questions that are commonly asked. Where can I go to if I need help? For a younger child, the staff have been identified to help will most likely be in their own classroom, so it's easy accessible for them. For an older child that may have many different teachers, they want to know who they want to go to and where they can go to contact that person. What should I do if my bag leaks, or can I leave the lesson? So it's useful to have prior discussions and make an arrangement for the quickest and simplest way for the child to leave the classroom without drawing much attention to themselves. For a younger child, they may be quite happy to go and tell a teacher, or if they're new to the school, not familiar with the staff or sat in a more formal lesson, it might be that they prefer to hold up a picture card or a coloured piece of card that indicates that there's a problem and that they need to leave the classroom, and so they both know what that means. For a secondary school child, they would require a toilet pass to allow them out of lessons, so this can be easily arranged within the school. Where shall I keep my stoma supplies? For a younger child, it's normally kept in a toilet or medical room where they'll be emptying or changing their bag. For an older child, they'll probably move from classroom to classroom, sometimes in much larger buildings, and sometimes even between buildings. So they'll need to carry their supplies around with them, or it might be possible that they have a locker close to a toilet that they'll be using. Where can I change or empty my bag? As I've said before, primary school children, they normally have a designated room where that will happen. In secondary schools, a number now have open plan toilets, and the children aren't comfortable in using those toilets to empty their bags. So it's useful to discuss which alternatives that they're going to be able to use and which are appropriate to use. These might be toilets in a less busy area of school. They might be disabled toilets or even staff toilets. Do I need to tell my friends? It's a very personal choice whether children can tell their friends. As we all know, children can be cruel, even friends can be cruel. And it might be that something that's talked through with their parents. There's no right or wrong answer. It might be just that they choose to tell their close friends in case, and if that's the case, it's useful to discuss what they're going to tell them, so they've got a prepared answer or response to the questions that they might ask. My experience with younger children is that, especially boys, is that they generally have no worries about who knows or who sees their bag, and they're often quite proud of it and they like to show it off. Some may be very happy to answer questions, and others might be more anxious and shy about talking about it. So some families ask to organise a show and tell session where they can use their stoma bears if they have one, and they can show this to their classmates, and they can get all the questions and answers out in one go. Will my stoma smell or make noises? This is a question that always worries older children, and especially if they're sat in a formal quiet lesson and their stoma decides to be very vocal. For younger children, especially boys, they just find it very funny. I would normally talk through how they could deal with that. So talking about avoiding foods and drinks that will give them wind, and maybe avoid those on school days. Or a lot of children will just turn around and they'll just deny all knowledge and lay the blame elsewhere. And just giving reassurance that when their stoma bag is on and intact, then that shouldn't smell. And if they do have a problem with a leak, they're able to leave the classroom as soon as possible. Will people be able to see my bag under my clothes or when I'm getting changed for PE or swimming? If children are worrying about other children seeing their bag when they're getting changed, it might be that an alternative place is arranged for them to get changed, or if that in itself draws more attention to them, they may be able to wear a support band over their bag, or on PE days maybe come in bottoms that they're able to wear for PE. So parental worries, I find that by involving the parents in the process and a parent being at the training session, they're party to all that information that's been given, and they're able to add anything specific that they want the teachers to be aware of. Parents want to ensure that they're going to receive the appropriate training so that their care is delivered as correctly, or that the staff will recognise if something is not right with the child or they're unwell and the parents need informing. If a child needs their bag emptying or the bag leaks and they're sat in soiled clothes, they want to be reassured that the staff are available to be able to attend to their child as soon as possible. There's always fears around teasing or bullying, and they need that reassurance from school that if this is an issue, then it's going to be dealt with in the best way and it's going to be dealt with promptly. They also want to ensure that when they're kept up to date with everything that's going on within the school day. A lot of worries schools tend to have are fear of the unknown. It helps if schools have had previous experience of a child with a stoma, or if staff have worked in other settings with experience, or family members with stomas. They often feel more happier and more confident. Whereas if they've had no experience, they sometimes are fearful of what they're going to be actually being asked to do, and they need some clarity about what the role entails. They want to know what training and ongoing support is going to be available to them, and whether they'll need any additional resources or funding. There is a possibility that staff may refuse to be involved or they're reluctant, but again, this is often due to lack of information and concerns about what they're actually being asked to do, or even a fear of litigation. When delivering the training, it's useful to ensure it's done prior to the child returning to the school where possible. So if anything needs to be put in place, that can be done in plenty of time. For all primary and junior school children, I would go into school to carry out training, as the majority of children will need some degree of help. Secondary school children are becoming more independent and might not want or need staff to go into school. The decision to give training is on an individual basis, depending on how capable the child is. But I would always encourage parents to arrange a meeting to discuss their child's condition, even if the staff don't need to be involved on a practical level. School need to identify a number of staff that are happy to be trained and are accessible to the child throughout the school day. Someone in their own classroom or a member of office staff or support staff that's able to leave the classroom when needed, and also more than one member of staff to cover any absences. A joint session including the school, the child and the parent is really useful, as you're able to cover both the theory and the practical side of things. The theory, I would cover the basics of what a stoma is, why the child has a stoma, the different types of stoma. I would also cover problems that arise, possible reasons why that might happen, and what to do in that situation. The Stoma Care in Schools and Nursery booklet describes a traffic light system that can be used as a guide to potential problems. So green, things such as leaks or redness of the skin, that can be documented in parents just informed at the end of the day. Yellow, maybe a change in output that needs a discussion with parents at the time. Or red would be a prolapse or a large amount of bleeding that the parents would need to be contacted immediately, and then they can seek the appropriate medical advice. It's useful for the staff that are going to be caring for that child to actually see the bag being emptied and changed, see what the stoma should look like, see how the parent does it and how the child, so what the child is used to and how they behave whilst it's being done. So then the school staff know what the norm is. Because a common fear for school staff is that it'll hurt them as it looks red, sore, and it could bleed. So seeing this isn't the case is very reassuring for them. If it's not possible for the child to be there to do an actual bag change, then we would just talk through that, or if there was a DVD available, you could show the DVD of children having their stoma bags changed. So other issues that arise as part of the school day: food and drink. The general advice is that there's no restrictions for children on diet and fluids. We would encourage a healthy, balanced diet. But if there's anything specific to that child, or if they're on a special diet due to any underlying conditions, they can be noted in the care plan. I would also stress the importance of having access to drinking water. As children get older, the schools often don't allow water bottles on the table. So it should be highlighted that they need that access to water throughout the day. Those sports, I would advise school that children with stomas are still able to participate in PE, as some children will try and persuade the school staff otherwise. And it's just advice regarding contact sports and also general advice regarding swimming with a bag. School trips. A child with a stoma shouldn't be prevented from going on trips. A little extra planning might be needed to ensure facilities are available if the bag needs changing, or a trained member of staff would need to be on the trip. If it were a residential, the staff would be mindful of who the child's going to be in a room with. So just ensure that it's going to be somebody that's comfortable, they're comfortable with. Keeping stoma supplies in school. They would normally have a bag that stays in school or comes to and from school on a daily basis. It's the responsibility of the parent to keep that topped up. And if the bags aren't being pre-cut, I would normally ask the parents to ensure that they cut them to size prior to sending them into school, as it takes that added stress off the school staff. So they're not having to worry about making sure that they're cutting the bag to the right size. And it's also useful to keep a spare set of clothes in school. So safeguarding. Changing a child's stoma bag shouldn't raise any potential child protection concerns. There are no current regulations to say a second member of staff need to be present. In my experience, it's normally the school that has a policy to say 2 members of staff need to be present. And if this is the case, it might be that the second adult just remains in the vicinity. So to try and preserve the child's dignity a little. I find staff initially like a second member of staff there just while they're learning, and it just provides them with a bit of reassurance and support for each other. It's important to maintain the child's privacy, so the room should be private with a door that closes. Toilet partitions are high enough so the children can't look over. As we all know, they can be very inquisitive. Health and safety. I would normally look at where they'd be carrying out their stoma care and assess whether the room's suitable. If there's hand washing facilities, gloves, aprons available, and also if the child is laying down to have their stoma bag changed, they would need some sort of changing station or adjustable bed, depending on their age. So encouraging independence, even from an early age, we can encourage the child to participate in their stoma cares, even if it's as simple as collecting their bag with their stoma supplies in, to getting it all out to make sure that everything's prepared, to spraying adhesive remover, helping spray adhesive remover to get the bags off, to actually changing their bag. Communication between the school and the parents is really important to ensure any relevant information is passed on. This may be face-to-face at the beginning or end of the school day, or through a homeschool book, so that prevents conversations having to be had in front of parents at the end of the day when it's chaotic anyway. So a child's level of healthcare need will determine if they have an educational healthcare plan. If their level doesn't meet the threshold, the school will incorporate their individual needs into a school care plan. The care plan captures the information and actions that are required to support the child effectively whilst in school. So all that information that's been discussed as part of the training session can be used. It's also key that the communication happens between everyone to ensure the needs of the child are met properly and they're properly understood and adequately met. But ultimately, the responsibility for that care plan lies with the school. Other documentation that's useful for schools is the Stoma Care in Schools and Nurseries booklet written by the PSNG. This has all the written information needed to support a child in school. It also has a training record in it, which incorporates a checklist to ensure all the relevant information has been discussed, and a section where professionals and parents can sign to say that the training has been delivered and that the parents are happy for stoma care to be given by that named member of staff. A copy can be left with the school and a nurse as a record of the training that's been given. Sometimes it's also useful for school staff to have a step-by-step guide on how to change the bag. Although staff may be emptying the stoma bag regularly throughout the day, carrying out a complete bag change might be less frequent, and how to do that's quickly forgotten. So a step-by-step guide using photos for the different stages can help jog people's memory. And the last slide just shows some policies and guidelines related to children in school with a stoma.
Thank you, Liz. Starting school can be a fairly stressful but exciting time for any young child and their parents. So it's good to know what process is required, as well as other helpful resources that are available that can make this significant milestone in both a child's and parent's life as smooth as possible. This episode is available to be viewed on demand at Sol's Healthcare website, so it can be stopped and replayed at your convenience, giving you time to write notes or reflect on certain aspects of the session if required. Please do email us at discover@salts.co.uk with any follow-up questions you may have, and also use the same email address to complete the evaluation form to receive your certificate of attendance. Our final session in Discover Series 2 will be launched on Thursday the 6th of May. In this session, we will hear from Claire Bohr, Paediatric Stoma and Bowel Management Nurse at Bristol Children's Hospital, who explores the psychosocial impact of having a stoma formed in childhood. We will also hear from some parents regarding how having a child that has undergone a stoma formation has impacted on them. Thank you again for watching, and we look forward to seeing you next time.